Bom dia a todos.
30是吧？30是吧？
Vamos dar início então à sessão de casos ao vivo. Meu nome é Daniel Chamié. Ao meu lado, o Dr. Shao-Liang Chen. Vamos diretamente para a China, em Nanjing. Bom dia, Dr. Chen.
Thank you very much. Thank you very much. It's a great honor to have my team to transfer 2 live cases from Nanjing, China to SOLACI. If you can you hear us?
Yes, we can hear you very clearly.
Okay, so thank you very much for your tough work. I know now, right now is the evening in China. So could you start to introduce your team and the case?
Yes, it's my honor to be here to have the transmission from Nanjing First Hospital, and I'm very lucky to be here. So today we will transmit a case of disleftment bifurcation lesion, and my right hand is Dr. Yu Wei, and right hand is Dr. Wu Xiangqi, and yes. Yes, and the intravascular imaging technician is Dr. Pan Tao, and have a lot of nurses working here and together. So I will introduce Dr. Yu Wei to introduce patient's characteristics first. Dr. Yu, please.
Dear moderator, thanks audience. Good evening. Here is the Nanjing First Hospital. We are in lab 4. Next slide, please. Today, our lab case is the 70 years old gentleman, and he was admitted to our hospital for recurrent chest tightness for 1 year, aggravated for 10 days. He had hypertension, and the blood test showed that this patient has the good renal function and the cardiac function, the EKG. We can only find the T-wave inversion leads V5 to V6, and echo shows the patient has the very good cardiac function. With the LVEF 60%. Next, please. So after the optimal drug treatment, we perform the coronary angiography for this patient. Next slide. 下一张幻灯, please. Okay, you can see, we just performed the case half a month ago, and it's right dominant, and you can see the severe stenosis just located at the proximal and extended to the middle segment of ICA. And the next, please. And the left coronary angiography, you can see very obviously the disleftment true bifurcating lesions. Next slides. Okay, you can see from the 2 corner views, especially the spider views, you can see very wide angle between the LVD and the circ. This is the Medina 111 true bifurcating lesions, and you can also, from the angiogram, you can see the moderate to severe calcium here. Fortunately, the lesion length for LVD is not so long, and we can see very clearly from the cranial view. Next, please. So usually when we encounter this kind of patients, disleftment bifurcating lesion and trifascial disease, we just ask the consultation with the surgeons, but the patients refuse the open chest surgery. So we decide the PCI and the step PCI for the patients. The first, we choose the ICA, cause the ICA dominant and the lesion is simple. And 2, domestic Chinese domestic stents was deployed just to cover the proximal segment of ICA, and you can see the result is good. So next, please. So after the PCF ICA, we calculate the left coronary, the residue risk score. The score 2 for the disleftment for the case is 20.47 and more than 19. And the syntax score 1 is 29. Syntax score 2, PCI is 25.5. and less than the cabbage. So the patient is very suitable for the PCI strategy. Next, please. And if we use the definition criteria to check the case, the case just qualify the one major criteria, and this three below minor criteria. So it's definitely complex disleveling bifurcation lesions. And the data from the definition 2 trial showed only the 2-stent technique can benefit patients and has the lower TF when compared with the provisional standing group. Next, please. So for this distal left wing, and we also check the mu-FR for this case with the LAD 0.6 and the circ just 0.78, equivalent with the angiography findings. So for this case, our strategy, 2 stents for this complex distal bifurcation lesion, I think is optional, is optimal for this case. But use the DQ crush or Q-lot for this disleveling true bifurcation lesions is our concern, and use the angio-guided or the intravascular imaging guided. So this is our case. That's all. Thank you.
So today's angio on screen. Yes. We will show the today's angio, and we also know we want to use intravascular imaging or functional test to guide our PCI for this case. So this is based on the angio. This is a diffuse lesion from the ostial circumflex to the distal. And there is a severe calcification located at the ostial and the distal left main bifurcation lesions. So this is a complex bifurcation lesion based on angio. So we want to use not only intravascular imaging, but also for the functional test for the guidance of PCI. So before PCI for this case, we measure the IVUS and mu-FR for this case. Dr. Pan will interpret the IVUS data and the functional data of the LAD and the circumflex. Dr. Pan, would you please introduce the IVUS findings?
Okay, can you see the IVUS imaging? Okay, that show the IVUS imaging. The first round we check IVUS from the distal LAD to left main, and here we can see this point is a distal LAD. The vessel diameter is about 3.2 millimeter. But here this point we can see the vessel is not normal, and we can see eccentric calcified plaque, but the plaque area is very small. So this point can do the distal landing zone. Then go on probe back, we can see here. This is a diagonal. This is the first diagonal showing LAD. Then go on probe back. This is a proximal LAD. The proximal LAD vessel diameter is more than 3.5. Yeah. Then go on probe back. We can see here. This is a proximal LAD. The calcification angle is about 180 degrees. Then go on probe back here. We can see here the guide wire circumflex we are showing LAD, and here we can see the ramus. Then go on probe back, this is a POC. And then here, this is the distal left main. The distal left main, we can see the plaque is a calcification, and the calcification angle is about 360 degrees. And the lumen diameter is just 1.75 millimeter. Then go on probe back, this is the body left main. The body left main vessel diameter is about 4.5 millimeter. Then go on probe back here, we can see this is the ostium left main. The ostium left main is not normal. Yeah, okay. And we measure the netness from the distal landing zone to the ostium left main is about 28 millimeter. And the distal landing zone to the first diagonal and the LAD bifurcation, the nest is about 7 millimeter. Okay, this is the LAD IVUS. And the second round, we check IVUS from the distal circumflex to left main. And here we can see the distal vessel diameter is about 2.5 millimeter, and the vessel is normal. Then go on probe back, we can see eccentric plaque, and the plaque is a calcified plaque. And here we can see the vessel is about 3.0 millimeter. Then go on. Here, this point you can see a big OM where join circumflex. Then go and pull back. This is a proximal circumflex, and the here proximal circumflex vessel diameter is about 3.5. And here, this is a proximal circumflex, and this point is the minimum lumen area, and the area is just 2.2 millimeters square, and the plaque burden is more than 76%. Then go and pull back. We will near the proximal circumflex. And go and pull back, we can see the ramus and the LED will join the vessel. And here, this point is the ostimal circumflex, and here the area is about 4.9 millimeters square, and the plaque burden is about 57%. We measure from the distal landing route to ostimal circumflex, the netness is about 41 millimeter. And the netness from the distal landing route to the circumflex and the OM1 bifurcation is about 18 millimeter. Okay, this is the baseline everything imaging. Thank you.
Oh, thank you very much, Pantao Yefei. While we have all information from angiography and IOS, I'd like to ask our panelists to for their comments and strategy for this case. Any comments?
Well, I think it's a very complex lesion. It's a complex patient. My question would be if you use in this such calcified distal left main some kind of atherectomy or some kind of plaque modification in some cases or no? How often do you use it?
Can you hear us?
Yes, we can hear. Based on the I was finding, we find the severe calcification located at the proximal area and the distal left main. For this severe calcified lesion, based on the IVUS, we did not know the thickness of the calcified lesion, and we also want to use some effective calcification modification or debulking. And but based on the IVUS, even though the minimum luminal area was minimum luminal diameter was so large enough, so the biggest burr in China means rota is a 2.0. I don't think rota is suitable for this case. Based on previous our strategy, we want to use cutting balloon, but still failed to find the any crack of the calcification. So after that, we use shockwave balloon to perform the modification for this calcification.
My question was exactly about
even though we also know that this left band bifurcation was
So we have a question from the panel.
My question was about shockwave. If you have shockwave balloon in China, you have?
Do you have shockwave balloon in China?
Yes, we do have.
Yes, so why not use shockwave for this particular case?
Yes, we use.
No, if the question is why don't we use shockwave for this case?
We use the shockwave balloon. We use the 3.5 shockwave balloon to pre-dilate the distal left main. So, yes, we use.
That's very good. So I see that you have
but
an intraotic
unfortunately, just
how many of the panelists here would use some sort of circulatory support for this complex left main bifurcation?
I would not. If the EF is normal, I don't use support.
You don't?
I just trust in support in very few cases, and if the EF is very low, and I think that I'm going to be doing a very long procedure, but I trust more in hands and than support.
Any different opinion? Some sort of circulatory support for the case? Or?
Yeah, any comment from our left side?
Yeah, so to sum up, this is a severely calcified lesion in the distal left main. That's probably the most important lesion in the vessel. And as the doctor was pointing out, although it's severe, the lumen is not extremely tight, so probably a rota won't be useful here. So in our practice, we will use shockwave as the first tool to work with this, and I don't think you're going to have any problems with support or whatsoever. What you have to do, though, is to prepare the lesion properly, one-to-one size to be able to work freely in the bifurcation, which is your final aim. I think that's what our...
So according to the IVO's findings, do you guys think just IVL is enough? Would you have in your mind any sort of additional preparation for the lesion, or just try IVL first and re-image?
Well, he does not. He's not using rota shock as a strategy. He explained why, and I agree. It's at first it's not so tight that needs to open up a hole before you come with the shockwave balloon, and after and rotablator after shockwave doesn't make too much sense. So now after shockwave, what usually I do, if it's still very calcified, sometimes use a cutting balloon like a Wolverine just to modify a little bit more the plaque. If the vessel is large, like a 4-0 vessel, this one, we can use a Wolverine before. But you can check in IVOS if it was a fracture or not, the calcium, right? You have to recheck and then decide.
From IVOS, in addition to very severe calcification from both LAD and proximal subflex to distal left main, also there is a very large calcified nodule localized at distal POC area. So Dr. Ye, we have had many comments from panelists. So can you introduce the procedure from the beginning?
Yes. Just we want a plan to use shockwave balloon to pre-dilate the distal left main. But unfortunately, after 3 times we use IBR, the patients feel uncomfortable, and we find that the blood pressure was lower down. At that time, we stop a shockwave balloon to pre-dilate the left main again, and insert the IPP to support the hemodynamic of the patient. After insert the IPP, the patient feel better, and we find that the blood pressure and the heart rate was normal, and then we check the angio, but the angio is okay. There's just no dissection, no slow flow of the LAD and circumflex. So we think the patient cannot tolerate the long-term pre-dilate of the distal left main, even though we should use intravascular shockwave balloon. After that, we check the IVOS, and Dr. Pan will introduce the IVOS after shockwave balloon. So, okay. Dr. Pan, could you please?
So that's a very good practical question. When you apply shockwave in the left main, usually you deliver the 10 pulses and you see how the patient feel, or you already anticipate that this is going to be a long inflation and then you just deliver shorter pulses, but you do it more times. How do you approach IVL in left main? And then I would like to hear the panel as well.
So for some cases, when we use shockwave left main, if the patient is intolerable to long process, so probably we only use 6 to 8 bursts each time, and then stop and to allow the restoration of blood. I think another important thing is that my team has used the IBP to support the patient because there is a sharp reduction in blood pressure during shockwave. A good strategy. Go ahead, Pan Tao, introduce the IVOS finding.
Daniel?
Okay, this point is the distal left main, and here we can see the crack very clearly at the 8 o'clock. And here the lumen diameter is more than 2.3 millimeter.
This is just after shockwave or non-compliant balloon as well, following IVL?
This is for the post-shockwave balloon and the post-IBP inserting, we can find the multiple crack of the ring shape classification.
Just after shockwave. Okay.
Yes.
Marco.
Yes.
Marco, do you have a comment?
So after.
Yes.
Yes.
I was thinking if I should make this comment or not, because it's
That's more.
kind of off-label. The way I was going to give some give some tips to use shockwave in the left
Yes, we
lane,
can
but,
see. Okay.
but as I'm proctoring for them, I was told that because usually we don't use in the regular way in the left main, but I better say that there is some quicker way of using. There are a little bit off-label, not so long inflations, just some tips like that. You don't need to do the pulse dilation that you go up to 6. You don't need to go do this exactly as the rule. So you can adapt some modifications for left main when the patient has tight left main disease and is not being adapted to that. Better not to give more details, but it's possible to do that.
Perfect.
So, Daddy, if you go ahead and introduce the process of procedure.
Yes, after we find the multiple crack of the classification, we just treat the circumflex first. We want to use DK crush tactic to treat the complex bifurcation issue. So DK crush was all the time was designed and promoted by Dr. Shao-Liang Chen. And after that, we pre-dilate the circumflex with a 2-5 NC balloon. After that,
Can you put angiography centrally?
Yes. Angio? Please
Right.
put the angio on the screen.
Okay, Andrew.
Okay.
Is Andrew now? Yeah.
Yes.
Okay.
So after that, pre-dilate with a 2-5 balloon, we insert a 2-5 stent, with domestic stent, 5 Hawk, 2-5-29 to cover the distal lesion of the circumflex to the proximal. After that, deployed with 12 atmosphere, and then we put another stent 30-13 5 Hawk to cover the austere circumflex to the proximal part of the circumflex with the 30 NC balloon put in the LED, and after deploying
if you stop right now, I'd like to ask my panelists about the standing technique. So according to the IOS and angiography, what's your standing strategy for distal left main lesion?
My strategy for the left main would be, so I usually prefer the decay crush with a nano variation of the decay crush. So I would do a nano decay crush in the left main. Does any of the panelists would do a different technique for the left main?
Left side.
Would somebody favor for a culotte stanting or
provisional?
No, we usually use DK crash in a regular way. Not too much crash, very short, but DK crash for all the big bifurcations.
Thank you.
Okay.
I like.
In this case,
we will use DK crash as well for this case. But what
LAD
I think what is of a concern is that my impression is that the LAD is not well prepared enough. From the eyeballs and from the angio images, you can see that the proximal LED is still not ready. So you might find a little bit of problem doing the DKS. Yeah.
So
I think both techniques, DK crush or clot, is possible here. But the angle is good for DK crush, so I think it's better for this case.
And these angles are actually very favorable for a nano DK crush. You don't have much. You don't need much struts hanging out in the left main, right?
it's also called mini decay crush. So from the positive decay crush, the protrusion is always recommended to be as short as possible. I think this is a typical case, complex distal left main bifurcation lesion according to definition criteria. So there is no reason to use a provisional because very diffuse lesion from third. Okay, Fei. So all panelists agree with yourself decay crush technique. Go ahead.
Yes. After put the stent from the austere to the proximal part of the circumflex with a 3-0 stent, and we
how long protrusion of
the
the
stent balloon little earlier, and put side branch ostium optimization. This is a very important step of the DK crush. After that, we find the ostial circumflex optimization. After that, we pull back the stand balloon and use 3O balloon to crush the stand first. That's because there is a big mismatch between the LED and the left main. So we use two balloon to perform crush. One is balloon size equal to the proximal LED reference with 3O, and another, this is a 4O NC balloon to crush the circumflex ostium stand.
So I think so far there are three very key points for DK crush. Once we stand inside branch, we can use stand balloon or another NC balloon to optimize side stand. Second point is we need to use a large balloon, NZ balloon, to complete crush stand protruding in the left main. Okay, if you go ahead.
Yes, after that we perform the first rewiring from the proximal part of the circumflex ostium, and after that, we check the IVUS. IVUS will find if the rewire position was good. So we will perform the first kissing. It was very easy. After that, after the first rewiring to the circumflex, we check the IVUS. Dr. Pan, would you interpret the IVUS finding after the first rewiring?
Can you put IVUS centrally? Put IVUS centrally.
IVUS, please put the IVUS on the screen. Yes.
Can you see the IVUS imaging?
Yeah, we can see, but you need to put IVUS image centrally. I mean, in the main
IVUS 放
screen.
到中间。
Right.
Okay. This round we check IVUS from the proximal LED to left main. And here we can see the side bench, one wire, two wire, and the main vessel wire. We can see three wires. So we can, I will move IVUS slowly. And here we can see here, the one clock. This wire is the guide wire is passing through the proximus here. And here, so this point in the middle of the side branch opening, we can see here, we can see two wire in side branch. And this wire is the side branch wire, and this wire is the rewire. And in the middle of the side branch opening, if the guide wire is already in the side branch, so the guide wire is passing through the proximus here. So this one, we check IVUS, can show the guide wire is passing through the proximus here.
Okay, thank you. I think it's very important to guide the real rewiring position by IVUS. Even it's somewhat difficult to understand, but it's very important. Thank you, Pando. So, Dr. Yip, you can go through the PCR procedure.
Yes, after confirming by the IVUS, we find that the rewire position is very good. So we use 1-to-1 NC balloon to cross the side branch ostium very easy. This angio picture can show. So we use the 3O NC balloon to push.
Can we have the angio in the big
without
screen?
any resistance.
Sure, Angio.
So after that, we perform first kissing. Then next.
What's the balloon
After
size
that, we
for
put
first
another
kissing?
stand that covers the ostium left main to the proximal LED with the 3O 29.
29.
And yes. After that, we use a 4O balloon to perform the pot. After that,
What's the balloon size for
we
first
perform
kissing?
the secondary wiring. After secondary wiring, we check the IVUS again. This is now what we should now. So, Dr. Pan, would you check the IVUS?
Okay.
After secondary wiring.
Yeah.
Okay,
The secondary
which
wiring,
balloon size
we
were
check
used
IVUS
for the
from
first
proximal
kissing?
LED.
I'm sorry?
Which balloon size were used for first kissing?
3O NC balloon.
Okay, and a 4O in the left main for a first spot.
Yep.
Thank you. Yes, full balloon for part. Go ahead, Pantao.
Okay, this point is in the middle of the side branch opening, and here we can see the guide wire in 2 o'clock. So here the guide wire is already in side branch. So the guide wire is passing through the proximal cell.
So we think the second rewiring position is okay. So we want to perform the second kissing, and we also use two 3O NC balloon, one in ARD and one across the side branch to the circumflex. So this is 3O NC balloon.
3O NC balloon.
Yes.
So did you cover the ostium of left main?
Dr. Pan? From the I was finding, we have the cover the ostium left main. Covered.
Yeah, here.
Okay. Very precise.
This is 3O NC balloon to the
Please show us angio.
ARD.
So now you are using 3O
Another
NC
3O NC balloon.
Okay.
Wait.
So it looks
No.
she has almost 7 steps, but each step is very easy.
Here we are. So I'm sorry. So the rewire was pulled out. Give me another wire.
So what the wire are you using? It's a hydrophilic wire.
Runs through or BMW. This is BMW.
This runs through.
Okay. So it's a very common during procedure to take the run-through wire.
Yes, we want to use a workhorse wire.
What's your preferable wire? Workhorse wire.
Workhorse? I like BMWs. I do hunt-throughs and Minamo.
For
me
me,
talk.
BMW wire, maybe
me
because
talk.
I am too old.
Me neither.
在我这儿。
Personally, I prefer to use the BMW wire to rewire side branch. It's a very stable for
Okay, test.
some cases with very, very ridiculous angle. So I could use the stabilized wire.
Give me 3O.
So this is the BMW wire in single flex, right?
Yes.
Okay.
Yes. It's quite easier to rewire the circumflex easily just because we perform the first kissing easily. So we open the side branch ostium. Keep it.
So
Give me another 3O NC balloon.
So regarding decay quatch technique, so the first kissing is very important.
This is what's the reason? We find that it's quite difficult to cross to the LED. Is quite.
I feel the guiding case is not good enough to strong support.
Yeah, there's just some crossovers. Give me 3O NC balloon. 3O NC balloon.
So for
Give me
some
another 3
case,
NC balloon.
if there is a difficulty to advance the wire into the single flex, so can use the balloon in the LD to anchor. So that's a very simple technique.
Yes, sometimes we use anchor technique. Just because. Okay. No, stop. Lose it. Yes.
So because we still have some time, Dan, what's your opinion about the provisional stepwise provisional technique for complex bifurcation lesion?
不要拿出来就放
So
着。
provisional for me is always my first option
Okay.
for lesions that are suitable for
We should take
provisional.
one.
When you have
No.
extensive,
Oops.
severe and extensive disease in the side branch, I already go for two-stent technique. And actually, this is a good question. There was a recently published, it's still online printing on euro intervention. They published a meta-analysis on complex bifurcation, PCI. And so provisional stenting is always favorable, but there is a subset of complex bifurcation lesions that benefit from two-stent technique. So it's not that two-stent technique is better when needed. So when you have a
都下去。
complex case like this, I would go for two-stent techniques from the beginning.
No, not this one.
Right.
Ostium circumflex. We push to the circumflex very
It
easily
depends on
with the
lesion
3O
complexity.
NC balloon.
I fully agree that provisional standing is the best strategy for I mean, simple lesions.
Yes, go up.
But for lesions like
Yes.
this, I would never try provisional.
Indeed.
I think
Someone from the left side would think about a provisional strategy for this left-wing bifurcation? Or to stand from the beginning?
Sorry.
So if now you finished the alternative inflection for some flags, right?
Yes. Yes.
So I feel there is no any
So we use
difficult-
two.
1, 2, 3.
Okay, done.
So 3 ONC in sync flags, 3-5 in LED.
Yes. Yes.
Yeah, also can you show us the
Give me four
image?
balloon.
Can you show us the image of second kissing balloon inflection?
After second balloon. Okay.
So I've got a question. Would you use the same size balloons for the first and the second kissing ballooning?
If you can
Yes.
you get
The same balloon.
so 3-0 for sync flags.
For circumflex.
Yeah, previously
3-5
used NC balloon.
for LED.
Once rewiring in
Two
the
NC balloon.
correct position, so there is no any resistance or difficulty to put the previous balloon into the side branch. That's okay.
So let's have a show of hands. How many of the audience would do a second part? So you did a first kissing, first part, then you stented, you recrossed, you did a second kissing. How many of you would do a second part to finalize the case? Show your hands. Not very much people, huh? So doing the second
Yes.
part after you did all the work is not something
Yes,
that is
go up.
consensual. Does any of the panelists would
Okay, down.
skip the second part for this case, or always you do a second part?
I mean, almost always, you know.
Almost always.
From time to time, something happens and you say, oh, it's time to stop. But we would aim to do a final pot. Yes, yes.
60%.
60%. Depending on the time of the day.
Yeah, by the way, why not 100%?
I try 100%. Sometimes we couldn't, but
Daniel,
always try to finish with second pot.
If I am using 3.0 for
Andy, we're going
3.5
to now.
for the circ and 4.0 for the LED, which is a huge area, sometime I do IVOC. If it is okay, it is okay.
For Paul, actually, conventional NC balloon does not work well because there is a very long shoot. So, for example, if the diaphragm stand localized in the body, and we use a long NC balloon to find the port, so it's easily to get edge dissection. So far there is a dedicated port balloon for final port. Also, another point that, my team has used the 3 5-hawk stand. We have many experience using 5-hawk stand, which is the best stand suitable for bifurcation because the side cell looks like very regular. So when you rewire using large balloon easily to increase the side cell diameter for side branch.
So 14.
So if you have finished the final part, so this is the 3-5 balloon
Yes.
for LED, right?
Yes. Yes. Got 3-5 to personalization the LED and okay done.
So if
After that we check the IVOS.
So Dr. if only 4 minutes left for your procedure.
Okay.
So after final part, would you recheck the IVOS for both vessels?
Yes, absolutely. Just because they based on the ultimate trial designed by Shao-Liang Chen, and we should get the IVOS optimization so we can get the future outcome better. Even though we use the IVOS, but we cannot get the IVOS certified result, so we cannot get a good result in the future.
You mentioned that for the right coronary artery, you use the Fire King Fisher stent. Which is the difference with the Firehawk?
So I think Firehawk is better. That's because depending on the, go to the back.
It's the same company but different stand.
was polymer-free designed. Yes, yeah.
This standard age is low dissection.
Yeah, can
plaque protein is not
you
more than
put IVUS
50%.
image centrally in the main screen? IVUS.
IVUS, please, on the screen.
Go ahead.
Is this from LED or left side?
This is a LED, proximal LED here.
Okay.
The standard mean diameter is about 3.0. The guide wire is circumflex.
Yes.
This is a POC.
Yes.
And this is a distal left main.
Calcified nodule still exists, but the lumen area is
Yes, yes.
big enough.
Yeah.
Every time you have a
Positive
calcified nodule, you
abdomen.
never
Yes.
have a circular expansion. So the area there is very important
Yes.
to be measured.
Yes.
I think it's fantastic.
Even though
result.
we also know there is calcified nodule there, but we don't know which strategy was used is effective for this kind of situation. Even though we use shockwave now.
Shockwave is the best way for
Yes.
calcified nodule.
So is everybody happy with the IVUS findings?
Yes, I agree. I think it's big enough. The lumen, some asymmetry in the proximal LED, but it's something that we would expect it. So I think it's fantastic results.
So Charlie, if you do plan to recheck IVUS for some flash,
Yes, absolutely. Yes, we check the IVUS.
6.2, 6.3.
Oh, yes, yes.
And
Yes.
more distal.
No. Just from here. We just want to check the osteocircumflex just because time is limited. Okay.
Okay, I will put back. It's in distal stand. The stand mean diameter is about 2.5.
Almost a 3.
So here is the expansion is good. Here diameter is more than 3. Here at 5 o'clock, we can see the LED, the POC. Okay, I will stop.
Yes.
So we are
Could you measure
running
some
out of time. Can you
osteocircumflex?
show us the circ area and then maybe the final angio, and we can switch to the next case,
Right.
please.
So
Yes.
Pandor, can you show the osteocircumflex IVUS, and then if you need to check the final angiography?
Yeah, this is the ostium circumflex. The area is about 6 millimeter square. And the LED, we can see here, this point is the minimal lumen area. The area, minimal
Spider
stand
view.
area. The area is about 6.1 millimeter square. And here, this point is the ostium LED. The area is more than 8.8 millimeter square. And this point, this is the distal left main. The distal left main area is about 11.
Big enough. I'm very happy.
So can we have the angio in the big screen just to see your final angiographic result?
Yes.
That's a fantastic IVUS
Previous one.
results.
This is a spider view of the final result. This is the AP quarter. This is spider view.
That's perfect.
Oh, very beautiful. Very
Beautiful
beautiful.
result. Congratulations there.
Congratulations.
So
Yes,
it's
this
time
is,
for us to move to the
aerocranial.
next case. Thank you.